Welcome to this e-lecture on nephrology for MRCPCH1. This is the second lecture in the past test series, and it's entitled Infections, Urinary Tract Infection and Hemolytic Uremic Syndrome. And I'm Nick Plant. I'm one of the paediatric nephrology consultants from the Children's Hospital in Manchester. The learning objectives for this lecture are firstly to understand the principles underlying the genesis of urinary tract infection, then to appreciate the controversies regarding the diagnosis, treatment and investigation of such infections, to become familiar with the key features of the commonest forms of hemolytic uremic syndrome, and finally to identify the differences between the diarrhea-associated and the non-diarrhea-associated groups of this disorder. Let's start off with a question. Question 1. Which of the following are typical presentations of urinary tract infection in a 3-year-old? Is it A, anal itch, B, loin pain, C, constipation, D, failure to thrive, or E, vomiting? This is a true-false question. So we can see anal itch, typical feature of worms, but not really typical of a urinary tract infection. Loin pain, I think that probably would be regarded as a typical presentation, particularly if there's upper tract involvement. Constipation can predispose you to getting urinary tract infection, but you don't typically see it with a UTI. Failure to thrive, response D, seen generally after protracted and recurrent urinary infections, but not with a typical acute infection. And vomiting, yes, we do see vomiting. Diarrhea and vomiting is indeed a typical presentation of a 3-year-old with an acute urinary tract infection. Let's do another question. Question 2, another true-false. Regarding urinary tract infection in children, A, they can be reliably diagnosed on history and examination. B, they require intravenous antibiotic therapy if there's loin tenderness. C, recurrent infections in children under 6 months merits investigation with ultrasound and MCG. D, they are commoner in males during the neonatal period. And finally, E, if a patient with a structural anomaly is diagnosed with a urinary tract infection, they should be treated with intravenous antibiotics. So let's have a look at the answers. You cannot reliably diagnose a urinary tract infection on history and examination alone, and you're going to need to examine the urine generally to make that complete diagnosis. So our A is false. B, if there's loin tenderness, the new NICE guidelines would suggest that you don't require intravenous antibiotics as long as the patient is generally well. So B is false also. C, NICE guidelines suggest that recurrent infections in children under 6 months do indeed merit investigation with an ultrasound, an MCG, and actually also with a DMSA scan. D, they're commoner in males during the neonatal period. This is indeed true. Infection in the urine is commoner in males during the first year of life. And finally, E, if a patient has a structural anomaly, they should be treated with intravenous antibiotics. That's false. There's no evidence to suggest that if you have a structural abnormality, it's mandatory that you require intravenous antibiotics. Some of them will be poorly, and some of them will need intravenous antibiotics, but by no means all of them. So E is false. Let's move on to the third question. Which of the following are associated with acute or recurrent urinary tract infection? A, hypospadias, B, hydronephrosis, C, vesicoureteric reflux, D, duplex kidney, and E, meatal stenosis. It's a true-false question. Let's look at the answers. They're all true. Hypospadias can be associated with recurrent urinary tract infection. You can get ascending infection more easily with hypospadias, and there are some upper tract abnormalities associated with it. Hydronephrosis is indeed associated with acute or recurrent urinary tract infection because largely the cause for hydronephrosis is going to be one of reflux or obstruction. That brings us on neatly to C, which is reflux, which does indeed predispose you to urinary tract infection. And while we're talking about obstruction and reflux, both of those conditions are seen more commonly in D, the duplex kidney. Although most duplex kidneys are without problems, they are more commonly associated with obstruction and reflux than simplex kidneys. And finally, having a meatal stenosis will cause a degree of urinary hold-up and therefore predispose you to urinary tract infections as you have relatively stagnant urine. Another question, question 4. Circumcision can cause which of the following? Another true-false question. A, sterility. B, orchitis. C, urinary tract infection. D, wound infection. And E, our old friend, meatal stenosis. Let's have a look at the answers. Circumcision cannot cause sterility, and circumcision does not give you orchitis. But the process of being circumcised can give you urinary tract infection, so C is true. But generally, we would circumcise boys who are getting recurrent urinary tract infections to reduce their incidence of infection because of the uropathogens that live underneath the foreskin. So circumcision can cause acute urinary tract infection acutely, but is generally done to reduce the incidence of such infections. With any surgical procedure, a wound infection is a complication, so D is true, and also circumcision can produce meatal stenosis. Question 5. A 1-year-old boy presents with a poor urinary stream since birth. Which of the following investigations would be most helpful in this case? So this is a best of 5. The responses are A, MCUG, micturating cysto urethrogram, B, ultrasound of the bladder, C, excretion urography, D, uroflowmetry, or E, a CT scan of the renal tract. MCUG is the most appropriate, most helpful investigation in these circumstances. This is because a 1-year-old boy who presents with a poor urinary stream since birth is most likely to have posterior urethral valves, and this is a condition that's diagnosed either by an MCUG or by cystoscopy. If we look at how the other responses can be listed in terms of their merit, we see A is top. Probably an ultrasound of the bladder would be the second most appropriate investigation, although clearly that would give you no information about the urethra, but you would see thickening trabeculation of the bladder. D, uroflowmetry, difficult one here, because to do uroflowmetry properly, a child has to be able to void to order, and clearly a 1-year-old won't be able to do that. But you may get some information from the ultrasound. The fourth best response would be excretion urography and IVP. Not terribly helpful because that's looking mainly at the upper tracts rather than the lower urinary tract. And finally, a CT scan of the renal tract would probably be as unhelpful as an IVP, because although it would give you good detail about the parenchyma, you're clearly not going to get any significant information about the urethra, although you may get some views of the bladder. So let's think a little bit about urinary tract infection. Urinary tract infection remains a significant issue because it is the commonest cause of end-stage renal failure and hypertension worldwide. The prevalence of urinary tract infection is difficult to be clear about, but a well-conducted study in the northeast of England suggested that by the age of 16 years, 12% of girls and 4% of boys had had a urinary tract infection. At any age and at any sex, E. coli is the commonest uropathogen, and as we alluded to earlier, the incidence of urinary tract infection is highest in the first year of life and declines thereafter, with boys being most commonly affected in the first year of life and girls most commonly affected from the first year of life till the end of childhood. Nobody's terribly sure about why this is the case. Some have suggested it's down to urethral length, but clearly that can't be true, as that doesn't change over time. And the most likely explanation is one that relates to some minor abnormalities of males' immune system immaturity in the first year of life. One of the important issues regarding urinary tract infection is its relationship to vesicoureteric reflux and scarring. So let's have a little think about vesicoureteric reflux. This is an anatomical defect caused by a relatively non-acute angle between the bladder and the urethra. It's seen in about 20 to 30% of children with a urinary tract infection. And generally speaking, many people would believe that if you have vesicoureteric reflux in the presence of infection, then about a third of individuals will go on to scar. And scarring is the most important consequence of urinary tract infection. This is an autosomal dominant condition with variable penetrance, and therefore there's often a family history, and the risk to siblings is about 50%. If you do nothing to refluxing ureters, then there is spontaneous improvement with time. The differential growth between the bladder and the ureter means that the angle becomes more acute, and the reflux ceases in about 15% of ureters each year. Let's think a little bit more about scarring. What's the prevalence of scarring? Well, difficult to say, but in another well-conducted study in the northeast of England, the prevalence of scarring was about 4.5%. And animal studies have shown that you have about 3 days from the onset of symptoms of urinary tract infection to treat the infection if you want to stop the scar from forming. It's also widely understood that if you have a urinary tract which is set up to have reflux, and as such reflux will predispose you to getting urinary tract infections, because obviously when you go and void, if 2/3 of your urine's passing into the loo and 1/3 of it is refluxing up into your upper tracts, then that refluxing third is going to be relatively stagnant and more prone to infection. So if you have urinary tract infection and you have reflux, then if you're going to scar, you will do so by the age of 4. If you haven't scarred by the age of 4, then generally speaking it would be unlikely that you would go on to scar in due course, and this is simply a statistical phenomenon. The significance of scarring is that it can produce hypertension and, if bilateral and significant, renal impairment. Scars produce hypertension as the relatively avascular scars can generate renin and aldosterone to drive up the blood pressure, and the risk is anywhere between 10% in the presence of a single polar scar up to around 50% if there's significant bilateral scarring. Renal impairment occurs as good nephrons are destroyed by scar tissue, and if you have severe bilateral scarring, then you could theoretically end up with end-stage renal failure. Here's a DMSA scan illustrating the presence of scars. On the left is a normal DMSA scan. The gamma camera is positioned behind the individual, so we have the left kidney on the left-hand side. And you can see on the normal illustration, both of the kidneys nice and reniform with isotopes scattered throughout both. On the right-hand illustration, the scarred illustration, at the top of the left kidney you can see a bite taken out, which is the scarred area, taking up the tracer poorly, and there we have a single upper left renal scar. Let's talk a bit more about urinary tract infection and how to diagnose and manage them, and this is a hugely controversial area. NICE guidelines were drawn up last year which were very different to what had been practiced previously. The NICE guidelines largely suggested that we were doing too many investigations and suggested that the investigations needed to be more targeted towards those individuals who are most likely to scar. The NICE guidelines suggest that urine's best collected by clean catch, although urine collection pads are sometimes helpful. They suggested that diagnosis should be made on either dipstick testing, and their assumption was that if you had nitrite positive and leukocyte esterase positive sticks, that would largely rule in urinary tract infection, and if you had nitrite negative and leukocyte esterase negative strips, that would largely rule out infection. They also advocated urine microscopy and suggested under certain circumstances that urine needed to be sent away for culture and sensitivity. The investigation of urinary tract infection remains similarly difficult. There's little controversy, however, about the 3 main investigations that are helpful. That would be an ultrasound scan, which largely gives you structural information about the renal tract, a DMSA scan, which remains the gold standard for scarring, and an MCUG, which is the gold standard for reflux, and the illustration shows pretty gross bilateral reflux on an MCUG. The investigation schedule, as drawn up by NICE, is quite complicated and beyond the scope of today's lecture. The illustration shows the algorithm from the NICE guidelines, which it would be sensible for you to become familiar with. They recommended far fewer investigations and less DMSAs and MCUGs than had been previously undertaken. The guidelines also suggested that antibiotic prophylaxis was not helpful and that very few individuals should be on it. They clearly stated that follow-up of such individuals was dependent on the initial investigations, but that all individuals who were scarred needed review, and that would probably be annual review of blood pressure. So let's leave urinary tract infection and move on to another question. Question 6. Regarding typical diarrhea-associated hemolytic uremic syndrome, A, the condition occurs most commonly in the summer months. B, a prolonged prothrombin time is usual. C, diarrhea is inevitably present. D, it is an uncommon cause of acute renal failure in the UK. And E, circulating antibodies to E. coli 0157 are frequently found. So this is another true-false question. So let's look at the answers. A, the condition does indeed occur in summer months. The 0157 organism is present in cow stool, and the organism replicates more rapidly in the warm weather of the summer months, so we do see more hemolytic uremic syndrome in the summer than at any other time. Response B, a prolonged prothrombin time is usual. This is false. This is a common catch. Clotting in the hemolytic uremic syndrome is normal. It is not elevated. C, diarrhea is inevitably present. I think the key word here in the stem is inevitably. Diarrhea is usual, as the name would suggest, in diarrhea-associated hemolytic uremic syndrome, but it's not inevitable. And some cases of non-diarrhea-associated HUS have diarrhea, and some cases of diarrhea-associated HUS don't have any diarrhea. Response D, it's an uncommon cause of acute renal failure in the UK. That's false. It's the commonest cause of acute childhood renal failure in the UK. And finally, circulating antibodies to 0157 are frequently found, and this is true. Usually, if we can't grow the 0157 in the stool, then we will check the blood and look for circulating antibodies. And in diarrhea-associated HUS, it's almost inevitably found, so the answer's true. Question 7. Causes of hemolytic uremic syndrome include A, factor H deficiency, B, ibuprofen, C, Salmonella typhi, D, E. coli other than the 0157 serotype, and E, metastatic malignancy. So this is another true-false question. Here are the answers. This is quite a difficult question, and this doesn't refer specifically to the diarrhea-associated HUS, but just to any form of hemolytic uremic syndrome. A, factor H deficiency. We'll go on to talk in due course about how the inherited forms of non-diarrheal HUS are indeed due to factor H deficiency, where there's an absence of this factor, which is a brake on the complement system, and complement runs wild in its absence, and you can get an HUS. Moving on to B, ibuprofen. Ibuprofen's a well-recognised cause of acute drug-related interstitial nephritis, but doesn't cause HUS. C, Salmonella typhi, is a well-recognised cause of HUS, particularly in Asia. And in the UK, although 0157 is the commonest serotype that produces HUS, many other E. coli serotypes can give you the disease, so D is true also. And finally, E, metastatic malignancy. Although uncommon, HUS can complicate metastatic disease. Question 8. In typical diarrhea-associated hemolytic uremic syndrome, the following are commonly seen. A, elevated serum amylase. B, rectal prolapse. C, a normal blood film. D, heart failure. And E, central nervous system involvement. And this is another true-false question. Here are the answers. A, an elevated serum amylase. Well, you can get elevated amylases because you can sometimes get involvement of the pancreas in HUS, but an elevated serum amylase is not commonly seen. It's an uncommon event, so that's false. The same applies to B, rectal prolapse. It's recognised but not common and is therefore false. A normal blood film isn't commonly seen in HUS, and virtually all the blood films in HUS will show fragmentation of red cells. Heart failure can sometimes be seen in HUS as a consequence of fluid overload or as a consequence of an extremely rare complication, which is direct myocardial involvement with HUS, but both of those are uncommon, so the answer to D is false. The only one in this list that's true is CNS involvement. And children with HUS commonly have mild CNS involvement in that they're irritable or miserable. More profound CNS involvement is also seen. So let's talk a bit more about hemolytic uremic syndrome. HUS is defined as the classic triad of a microangiopathic hemolytic anemia in combination with thrombocytopenia and acute renal failure. It's important to remember in the classification that there are two types of HUS. The much more common type is the diarrhea-associated, also known as enteropathic or typical HUS, which from now on I'll refer to as D plus HUS. And around 90% of HUS in the UK is D plus. The remaining 10% is so-called atypical or non-diarrhea-associated, non-enteropathic or D minus HUS. And we'll look now at the various causes of these. The causes of the D plus HUS, as we alluded to earlier, are largely in this country E. coli and most typically E. coli 0157, although the other serotypes are often involved. Less so in this country, but certainly in Asia we see quite a lot of Shigella, Salmonella, Yersinia and Campylobacter. But together, those 5 organisms around the world cover most cases of diarrhea-associated HUS. The non-diarrheal form has quite a diverse list of different causes. Infections can do it, such as typically Streptococcus pneumoniae. It can be drug-associated, cancer-associated, bone marrow transplant-associated, and sometimes seen with other glomerular injuries. And there are the important group of inherited forms which have a deficiency of factor H and often a low plasma C3. We'll talk about the various types in a bit more detail. So let's consider D plus HUS to begin with. This is the commonest cause of childhood acute renal failure in the UK and usually relates to the 0157 serotype of E. coli. This is known as the VTEC 0157, standing for verotoxic E. coli. And vero cells are green monkey cells. And in the laboratory, the toxin exuded by the E. coli destroys the vera cells. If you have 0157 in significant numbers, then around 10% of individuals will indeed progress to develop HUS. The way that you acquire the disease is to ingest cow stool, and this happens in a number of ways. Most typically, it's beef carcasses getting contaminated with stool in the abattoir. So what happens if you're making hamburgers is that you take the beef and the stool and they're mashed up into a patty. The patty's heated, perhaps not perfectly, so the outside of the patty's cooked, but the inside gets warm and the organism replicates in the middle of the beef burger, and then when you eat it, you get a good dose of 0157 and develop HUS. Clearly, if you're eating joints of beef, you're not going to develop HUS, because if there is any contamination of stool, it'll be on the outside of the joint, and that's the portion of the meat that gets the hottest in the oven. So the organisms are destroyed on the inside, on the outside, and on the inside there aren't any organisms because you can't contaminate the centre of the joint. Other sources of 0157 have been milk, and milk can be contaminated with stool also. There was an outbreak in the northeast a few years ago in a small farm where the milk was contaminated and then delivered in a small round. Water can be contaminated by stool. Apples can fall off the trees into the stool, and there was an outbreak related to apple cider a number of years ago. And any product that contains milk or water, or where meat becomes directly contaminated, can be a source of HUS. Children with HUS usually develop it between the age of 1 to 4 years. It's a disease largely that spans from May through to October, and there's no sex ratio. What tends to happen is the child presents initially with bloody diarrhoea, and as the bloody diarrhoea settles, the renal failure takes hold. And the bloody diarrheal prodrome usually lasts for an average of about a week. As well as the kidneys being involved, there are other extrarenal sites. Obviously the colon's involved, hence the colitis and the rarer complication of rectal prolapse. You can get a hepatitis, and as we mentioned in one of the preceding questions, CNS involvement is very common. It's said to be serious in around a third of cases where it's present, and those individuals can be obtunded or restless and very rarely can have fits or strokes. Pancreas can be involved and is said to be so in just less than 1 in 10. Sometimes this can be mild, and sometimes individuals can be overtly diabetic, and this is usually transient, although sometimes permanent. and as I mentioned earlier, heart involvement is rare. So what happens? Why do you get HUS? What happens to the toxin? Well, the toxin binds to VT1, VT2 and GB3 receptors that are seen most commonly in the kidney, but also in the other sites listed above. When the toxin binds to the receptors, there's inhibition of cell protein synthesis, activation of cytokines and platelets, and you end up with endothelial cell swelling. And as the endothelium swells, that causes further mechanical destruction of platelets and red blood cells, and you end up with the hemolytic anemia, and as the vessels become occluded, you end up with the acute renal failure. The treatment of D plus HUS is largely supportive. Nothing has been shown over the years to help with the disease to change its course in any way. And largely, if you require dialysis, you'll get it, and typically we're dialysing children for around 10 days with D plus HUS. If you need a blood transfusion, then that's given, and very, very infrequently platelet transfusions are required, with the same indications for a platelet transfusion as you'd see in something like idiopathic thrombocytopenic purpura. So what's the prognosis in D plus HUS? A recent study suggests that around 80 to 90% of individuals will make a full initial recovery. 5 to 10% of people will die acutely, and a further 5 to 10% will go on to end-stage renal failure, which, as we know, is defined as the sudden need for dialysis or transplantation, which equates to a GFR of around 15 mL per minute per 1.73 metres squared. Another study showed that around 20% of people will either have end-stage renal failure or significant renal impairment, and a further study demonstrated that between 20 and 60% of all individuals who've had D plus HUS will go on to develop proteinuria and or hypertension. I think the key message from these studies is that individuals with D plus HUS need to be followed up fairly assiduously and for quite a long period, and that it isn't generally a desperately benign disease with respect to long-term renal prognosis. Moving on from D plus HUS to consider D minus HUS. The presentation of D minus HUS, as the name suggests, is somewhat different. There's usually no diarrhoea, and there's often a more sudden onset, and they will present in acute renal failure with pallor and with thrombocytopenia and possible bleeding. So there isn't any diarrheal prodrome. And the other key difference between D plus and D minus is that the D plus group often relapse, and this isn't seen typically in D plus. Let's just look through the causes of D minus HUS. We know that they're infection related. The main cause of D minus HUS in this country relates to a nasty pneumococcal infection. These individuals are often very unwell, they're quite toxic, and they have a pneumonia. And the pneumococcus strips the T antigen and exposes it. And the T antigen reacts with anti-T antibodies to set up the HUS process. And this is quite a nasty complication for an individual who's already fairly unwell. Aeromonas species has also been reported as causing infection-related D minus HUS. Drugs are quite a big group that cause HUS also. Chemotherapeutic agents such as bleomycin, mitomycin C and cyclophosphamide all can produce a D minus picture, but generally when the drug is stopped, the HUS disappears. The oral contraceptive pill and pregnancy in older paediatric patients have also been shown to cause HUS. It can be related to malignancy, and typically metastatic malignancy can trigger D minus HUS. Bone marrow transplantation can produce D minus HUS, as can other glomerular injuries such as our old friends membranoproliferative GN and HSP nephritis. And interestingly, there have been some rare reports of congenital nephrotic syndrome producing D minus HUS. A really significant and important group are those individuals who have inherited or familial D minus HUS. This can be autosomal recessive or autosomal dominant, and the key feature here is that these conditions usually relate to an absence or antibodies to factors H or factor I. There are other subfactors that are sometimes involved. If we think about factor H, which is the commonest of all of the factors that's involved, and this, as I mentioned earlier, is a brake on the complement system, and in its absence, complement drives on relentlessly, producing HUS. These diseases are very nasty. They're the ones that typically recur, and usually after each recurrence there's some loss of renal function, and renal function can deteriorate in a stepwise fashion, and many of these individuals will progress to end-stage renal failure relatively quickly over a number of months or years. With some forms of the inherited form of D-HUS, the disease can recur in up to 90 to 95% of transplanted organs, and that really precludes transplantation as a viable treatment option in some cases. Let's think about the treatment of D-HUS. This largely depends on the underlying cause. For infection-related causes, if you treat the infection, things tend to improve. And for drug-related causes, if you stop the drug, we tend to see some improvement in the HUS. The familial forms, on the other hand, are often treated with fresh frozen plasma. And this is because FFP contains factor H. And if you can infuse factor H on a regular basis, you can attenuate the disease progression. If we think now about the prognosis in general of D-HUS, then clearly it's worse than the prognosis in D+. If you look specifically at the inherited forms, then a recent study showed that around a third of all children who have the inherited forms develop end-stage renal failure. A further third had chronic renal failure, and only 20% of them have made a full recovery. Let's finish off with a question. Question 9. A 3-year-old presents unwell with chickenpox and 2 large infected lesions on his anterior chest wall. He's voided once in the last 24 hours. His systolic blood pressure is 75 millimetres of mercury. The following results are noted. Hemoglobin, 9.9 grams per decilitre. White cell count, 7.4 times 10 to the 9 per litre. Platelets, 25 times 10 to the 9 per litre. Sodium's 130 millimoles per litre, potassium 5.5 millimoles per litre, urea 12.5 millimoles per litre, and his creatinine 142 micromoles per litre. His bicarbonate is 14 millimoles per litre. In this best of 5, which is the most likely diagnosis? Is it A, post-infectious glomerulonephritis, and that's a term that is largely synonymous with post-streptococcal glomerulonephritis, or B, ITP, C, HUS, D, varicella pneumonitis, or E, septicemia? The most likely diagnosis in this case is going to be E, septicemia. What you have is a 3-year-old who's got infected lesions following his chickenpox and is septicemic as a consequence of that. The things that would suggest that is that he's hypotensive, he's oliguric, he's got an elevated urea and creatinine, he's acidotic, and what we see is a low platelet count in a response to his septicemia rather than in response to HUS. You don't tend to see HUS following chickenpox, so that excludes that as a diagnosis, and it's unusual to see post-infectious glomerulonephritis after varicella, although it has been reported. But clearly, if he had a glomerulonephritis, you'd expect his blood pressure to be higher and you'd expect to be given some additional information. He doesn't simply have ITP, his platelet count is low, but there are no other features to suggest that. And it would be unlikely that he had varicella pneumonitis because this tends to come on quite late in the disease, and there are no comments made about respiratory involvement. So overall, E, septicemia, is going to be the most likely diagnosis. So just running through the order in which the answers would apply, I think E, septicemia, would be number 1, HUS would probably be 2nd, ITP 3rd, with glomerulonephritis 4th, and varicella pneumonitis 5th. So finally, the key learning points. Firstly, urinary tract infection is common and can have significant complications. Secondly, we've seen that the new NICE guidelines have recently outlined how to diagnose, treat and investigate urinary tract infection, although there has been some controversy about their use. Thirdly, diarrhea-associated hemolytic uremic syndrome is the commonest cause of acute renal failure in the UK. And finally, non-diarrheal forms, usually if inherited, often have a poor prognosis. Thank you.